Hello, hello. Welcome everyone to the undergraduate seminar. Today we have a more applied talk, Quantifying Bias in Care of Critically Ill Patients. This is by Sarah Walker of St. George. Yeah, Sarah, take it away. Thanks for coming out today.
Yeah, hi. So I'm Sarah. I'm entering my third year in computer science at the University of Toronto. And I'm going to talk a little bit about a research project that I'm doing this summer through the TKM AI in Medicine Summer Research Program. So as mentioned, I'm going to be talking about bias in the care of critically ill patients. So bias, by that I mean specifically with respect to race and sex. And by critically ill patients, these are typically patients that are in the ICU, they're at high risk of death, and they are frequently on life support. My supervisors for this project are Dr. Christopher Yarnell, who is an ICU doctor and epidemiologist, and Dr. George Tomlinson, who is a biostatistician at UHN. Oh, can I not change? Okay, there we go. So just to talk a little bit about what I'm going to cover in this talk, I wanted to talk a little bit about, why we're doing this study, why we're asking the questions that we're doing, what data we're using and how we're modeling it. This is the more mathematical part of the talk. And then I'll cover a little bit about our preliminary results and what we hope to do in the future. So just a little bit of background information. We're looking at patients in the ICU or intensive care units, and they can come to the ICU for a variety of different reasons. For example, cardiovascular conditions like heart failure, respiratory conditions like your lungs not working, or other neurological conditions. And you can be admitted to the ICU from different areas. So for example, you might call the ambulance, get taken to the emergency room, and then after some time there, you might get admitted to the ICU for sort of closer care. Or you might be doing some complicated procedure, and then after that, the doctors might admit you to the ICU just in case of any risks or further complications. But overall, the ICU is generally very organized and is meant for this constant close care. So each patient might, have a nurse constantly looking after them and their vitals and making sure that everything's all right. So as previously mentioned, in the ICU, a lot of patients are on life support, and ventilation is one kind of life support. There are different types of ventilation, but I want to talk most about invasive ventilation. This is an example of an endotracheal tube, which either connects through the nose or the mouth and goes all the way down to your lungs. This is a type of invasive ventilation. But this can be super uncomfortable for patients, even to the point where patients might try to rip it out themselves. So one solution to that is that doctors might prescribe sedation, as it's known to reduce anxiety or improve tolerance of invasive ventilation. But there are different ways that sedatives can be administered. So first of all, there's different types of sedatives. Propofol is considered one of the better options as compared to something like benzodiazepines because it's associated with a shorter length of stay, meaning that patients might get discharged earlier. There are also different ways that you can administer it. So for example, there's been studies looking at continuously administering sedatives as opposed to taking breaks partway through. And actually they found that continuously administering sedatives is associated with a longer length of stay and a longer time on ventilation. So all in all, we get this sort of trade-off between, wanting to minimize the amount of sedation a person's getting so that they're not, risking these more negative outcomes, but also, we want to make sure that they're getting enough so that their stay is, tolerable. So in the care of critically ill patients, there's a lot of ways that implicit biases can affect patients. So for example, there was a study done looking at this tool called a pulse oximeter, and it measures the amount of arterial oxygen saturation in a patient. And they were looking at how it compares with white patients versus Black patients. So for example, on the x-axis, you can see that this is the amount of oxygen saturation that the tool measures. And then on the y-axis, it's the actual arterial oxygen saturation. So for example, at 89, you can see that the median for white patients is about, 89 as expected, but for Black patients, it's much lower, maybe 86 or 87. And overall, the study found that there are these discrepancies between white patients and Black patients. They found that the tool typically overestimated the amount of arterial oxygen saturation in Black patients. And this can have negative outcomes such as delaying supplying additional oxygen to these patients. This is actually more of like a regulatory issue. So for example, like regulatory bodies like the FDA should make legislation saying that the manufacturers should change or accommodate this issue. But there are other ways that implicit biases can affect care. So there was another study that was looking at age and sex as predictors of admission to the ICU. So along the x-axis, we have different categories of age, and along the y-axis, we have generally like number of patients admitted to the ICU. And this study found that from patients above the age of 50, women were less likely to be admitted to the ICU than men. And that sort of corresponds with what we see in the graph, with the patients at about 80 to 89, the men are just under, twice, or admitted just under twice as much as women. There are other ways that implicit biases have been shown to affect care. So for example, there was a study looking at Asian American patients at the end of life care, so just before they died, and they were found to receive invasive ventilation much more frequently than other patients. And then there was a study looking at Black and Hispanic patients showing that they are more likely to die in the hospital than white patients. And there was another study looking at how women were less likely to receive lung protective ventilation than men. So overall, there's all kinds of ways that implicit biases can affect the care. Us specifically, we're looking at patients who've received invasive ventilation for at least 24 hours. What is the association between race, sex, and use of intravenous sedation? So just to break this down a little bit, first we have the patients who've received invasive ventilation. This is sort of the general cohort, the general common feature that all the people that we're studying are going to have. We want to make sure that they're receiving invasive ventilation for at least 24 hours because some patients can be intubated in the ICU and extubated very quickly. So there's not a lot of data for these patients and wouldn't be super descriptive or helpful in the long term. Then we have our research question, the association between race, sex, and use of intravenous sedation. So we're looking to see if our exposures, race, and sex have any impact on the outcome use of intravenous sedation. So we're doing a retrospective cohort study, meaning that it's an observational study looking at a set of patients over a period of time who have all been exposed to some particular variables. And we want to see if these exposures have any impact on getting impact on the likelihood of getting a particular outcome. So in our case, we have one exposure, and that's race or ethnicity. From our data set, we have these 4 categories: Asian, Black, Hispanic, and white. And our other exposure is sex, so we have male and female. Our outcome is the dose of sedation. And as previously mentioned, there are different kinds of sedatives. So in our case, we're just looking at propofol and benzodiazepines because these are the 2 most popular ones. Although in the future, we do hope to sort of look at a joint analysis of these 2. So overall, this composes our retrospective cohort study. Just to talk a little bit more about our data sets, we're using the Medical Information Mart for Intensive Care, the 4th version, also known as MIMIC-4. It's retrospectively collected data from one particular teaching hospital all the way in Boston called the Beth Israel Deaconess Medical Center, or BIDMC for short. There's about 40,000 unique patients or 70,000 unique patient stays, as one patient can be admitted and then discharged and readmitted later on. And these patients span from about 2008 to 2019 inclusive. And generally, these patients skew on the older side. From the patients that we're looking at specifically, most of them are over the age of 65. So as previously mentioned, we have quite a number of patients through the database as a whole, but we're not going to be using all of their data. So we have this eligibility flow chart to determine who's going to be relevant for our study. So first, we want to make sure everybody has a gender listed, as that's our first exposure, and everybody does. And then we want to make sure that everybody has a race or ethnicity listed. And actually, some patients didn't have a race listed, or it was listed as other or multiple. And we excluded those patients just because that's, not super descriptive. And then we want to make sure everybody's received invasive ventilation. And this actually takes out the majority number of patients from our study. And then from those, we want to make sure they've received it for at least 24 hours. There are a few other things that we have to look at. So tracheostomy is another type of invasive ventilation, but we're not including that just because of the way that it would impact a clinician's decision to administer a sedative. And then there was a few data points where the patients were listed as dead before they received invasive ventilation. So for that reason, we're going to exclude those just because we want to make sure all the patients are alive when they're receiving invasive ventilation. But overall, we get from about 70,000 unique patient stays to about 10,000 relevant patient stays for our study. And each of these patient stays have a number of time intervals corresponding to each of them. So I'm going to talk about how we're dealing with time in this for now. So let's say a patient is admitted to the ICU at some given point in time, and then they're decided that they are going to start receiving invasive ventilation. And then 24 hours later, they're reaching our point of eligibility. So now we think they're eligible for our study. And then say they continue receiving invasive ventilations for another 7 days or so. So now they've been on there for about 8 days. Well, we're going to exclude all of these data points in red. So we're not going to be using those for our model. But the reason for that is because we want to make sure that there's a sense of consistency between all of our patient data. So if a patient is receiving the ventilation for, a month, 3 or 4 weeks, the factors that would impact how much sedation they're getting at the end of those 3 or 4 weeks might be a lot different than however much they're getting at the very start. So we end up with this about a week or so in between. Of course, that varies if the patient gets discharged or extubated early. But from this time, we split it into 4-hour time intervals. And I'll talk more about this later, but essentially the reason for that is because we want to minimize the amount of time or the delay between the data collected in one time interval to the next. And the reason for that is because we're going to be using all of the data collected in the time interval 0, for example, to predict the amount of sedative a person is going to get in the next time interval. So this is how we're dealing with that. And as previously mentioned, each patient might not stay receiving invasive ventilation for that full week. As we can see on the x-axis, we have the maximum amount of time intervals of patients receiving invasive ventilation. And then on y-axis, the number of patients. So actually quite a number do stay for that full 42 time intervals, but a number of patients also die or get discharged or extubated within the first day or so. But essentially, we get a number of repeated measures for these patients. So each patient stay has a number of time intervals associated with it. So here's another example. We have 4 sampled patients on screen. So for example, patient A, they're not receiving any propofol at all for the entire, 7 days. But patient B, gets discharged or extubated early on. Patient C starts off with getting some propofol, and then that generally decreases over time. Whereas patient D, starts off with quite a bit, and then it decreases, and then it spikes again. So this is actually interesting because you could expect that a patient's the amount of propofol a patient is getting at one particular time interval is more related to however much they're going to get in the next time interval or the one previous, as opposed to another patient's dose at some other random time interval. And this is important because if we were to run something like a linear regression on this, then we would violate one important assumption, which is the independence of residuals assumption, meaning that in consecutive time data, the residuals of each point must be independent of one another. And if they're in between patients, that might not necessarily be true. So how exactly are we going to get around this? Well, we're going to be doing multi-level modeling. So this is a generalization of linear models like the linear regression, but it allows us to deal with this sort of clustered or nested data structure. So we have our cluster of patient. And then within each patient, we have a number of time intervals. So we have this equation here. Subscript I is for the level 1 time, subscript J is for the patient stay. And then our Y is a scalar for the outcome for some given time interval I or patient stay J. So for example, it's the amount of propofol a person might be getting at that point in time. And then X is a vector of predictor variables for that same time interval and patient stay. This alpha value is our intercept. So if all of the predictors were 0, this would sort of impact what the outcome would look like. But through multi-level modeling, we can split it into 2 parts. We have this average intercept over the population, plus some deviation from that intercept to account for this particular patient's stay. Another way to think about it is that the 2 extremes would be, we would say, well, every patient is unique and every patient would have a different intercept. And knowing the intercept of one patient tells us nothing about some other patient in the population. Or we can say every patient is identical and they're all going to have the same intercepts and there's no individual factors affecting the outcome at all. And of course, as is with most things, the answer or the optimal solution is somewhere in between. So that's why we have this average intercept, some information about the population, plus some deviation or some individual factors. Another way to think about it is if we say the patient has some effect on the outcome, then that true effect can be drawn from a normal distribution with some random mean or standard deviation. But if we're looking for the estimated effect, we can assume that it's drawn from a second normal distribution where the mean is the same as the true effect, but the standard deviation from the standard error. So similarly, we have slopes for all of our predictor values, and we can split them up into 2 parts the same way with an average slope and a deviation from the average to account for some patient stay. We're not actually doing it like this because we don't actually include random effects for predictor variables, because what it means would be saying that we expect some kind of linear deviation for each predictor variable based on patient stay, and which might be possible, but is a little bit less, I guess, useful overall than saying that each patient has some other individual factors that would affect the outcome as a whole, other than the predictor variables that we're including. And then, of course, we have residual for this particular data point. So as is with most regressions, we're looking to find these intercept and predictor slope variables, as we know the outcome and we know all of our predictor values. So I'm going to talk a little bit about the covariates that we're including. There's quite a few, so I'm not going to go over all of them, but they can generally be categorized into 2 parts. We have baseline factors, and these are ones that don't change over the course of a patient's stay. So for example, age, English fluency, or insurance type. So if a patient doesn't know English upon first receiving invasive ventilation, they're probably not going to know it by the time they get extubated. And then we have our time varying predictors like blood pressure or heart rate. So this changes over time. So we're going to get a summary of these values for each 4-hour time interval. So this is an example of some of the data that we have. So we have our stay ID. This is the patient stay. And in this example, we have 2 different patients. The first patient in blue, has about 20 hours of receiving invasive ventilation, where the second patient has quite a few. And then we have our outcome. So the first patient, I'll talk more about the quantiles in a bit, but essentially the first patient, starts off with receiving quite a bit. And then that decreases, and the second patient is sort of at a steady amount. So then we have our age and height. These are examples of our baseline variables. And as you can see, the age and height values don't change for that patient's time intervals. But then we get our time-dependent variables. And as you can see in row 1, it's about 0.3, and then it goes up to about 0.7 for heart rate, and so on. So this changes for every time interval. You might actually be wondering, well, heart rate should be between like 0 and 100, right? Well, based on the model that we're using, it prefers to have like the distribution numbers in a particular way, less spread out, closer to 0. So for that reason, for a lot of our continuous variables, we transform them typically through running it through the log function, the natural logarithm function. And we center and scale as well. So for example, if we're looking to predict the amount of propofol a person's getting in the next 4 hours, well, we have our baseline variables like the age, our time-dependent variables like heart rate, and our exposures like race. So we'd expect these all to have an impact on the outcome. And then if we're looking for the 4 hours after that, well, age and race will still be the same. So we'll still expect that impact, but heart rate will probably have changed. So we need to update that value and use that the updated value to predict. And similarly, we might want to look at the amount of propofol administered in the last 4 hours to help us see how much they're going to get in the next 4 hours. Speaking of outcomes, you can see that along the x-axis, we have the amount of propofol administered for a time interval. And then the count is the number of data points corresponding to that. And at 0, we have this huge spike. So a lot of data points, a lot of time intervals, patients aren't actually receiving any propofol at all. But as previously mentioned, the model likes if your distribution is in a certain way, and it doesn't work that well if you have a huge peak at one point and then a much smaller distribution elsewhere. So for that reason, we're turning it into quantiles. So the quantile 1 here is representing not receiving any drug at all. And then from the data points where the patient is receiving some drug, we split it into the 4 quartiles and then have those as the next 4. So that's 1 to 5. And these are unadjusted results. So, not particularly helpful in terms of like statistical significance, but we can already see some differences between the categories. So for example, Hispanic patients appear to receive higher doses of propofol more often than the other categories, and similar for male as well. So since our outcome is now this ordinal variable instead of linear, or continuous, we can't run a linear regression anymore. So instead, we're going to run an ordinal logistic regression. And this is sort of a generalization of the logistic regression, which is when your outcomes are a binary value, either 0 or 1. So in our case, we have these 5 categories. And the equation looks something like this. So we're looking for the cumulative probability of getting some category K, or less than or equal to some category K, given our vector of predictors X. And we're actually going to have K minus 1 of these equations, 1 for each category. And we don't include the Kth one because that probability will always be 1. And this is equal to some inverse link function. In our case, we're using the logit function, which looks something like this. So we have our alpha, which is our intercept with respect to our category K. So each of our K minus 1 equations will have a different intercept. But the beta slope vector will be the same across all of our equations. And you might notice that we're actually subtracting the predictor values. And the reason for that is because it makes interpreting the results a little bit more intuitive. So if some slope was positive, then that would indicate that that particular predictor value increases the likelihood of getting a higher outcome category. So getting more drug. So in our code, we're not actually, doing all of this, but I'm using R. So this is the BRM package. And we have our outcome quantile as the outcome, and then we have our exposures. And you might notice that we have 3 different variables for race. So actually we had our categories for race were Black, Asian, Hispanic, and white. But the reason that we only include 3 of these is because since it's a categorical variable, we're going to turn it into, we're going to one hot encode it, meaning that each of the categories will become a binary value. So if a patient is Black, then Black will equal 1, Asian, Hispanic, white will all be 0. But the reason why we don't include all 4 in the model is because it introduces something called perfect collinearity. So that means that you can perfectly get the outcome of one of the values based on the other ones. So if Black, Asian, Hispanic were all 0, then for sure white has to be 1. So for that reason, we only have 3. And the same reason for why we only have female as opposed to female and male. And then we have our baseline variables. This part indicates that we're clustering by stay ID, or the patient's stay. And then these are our time varying variables. And this family equals cumulative indicates that we're using an ordinal logistic regression. So now I'll talk a little bit about our preliminary results. These are just on a subset of our data, so not all of our data. But this is our posterior hazard ratio. So white is our reference. And then we can see that Hispanics at 1.07 with a 95% confidence interval of about 0.83 to 1.35. So it's a little bit above the reference, but it still overlaps 1. And then black is at 0.97 with a 95% confidence interval of 0.81 and 1.17. And Asian a little bit lower than that at 0.88 with a 95% confidence interval of 0.69 and 1.12. And as for our sex exposures, we have male as our reference, and then below that female is at 0.86 with a 95% confidence interval of 0.76 and 0.98. So interestingly enough, female doesn't actually overlap the one of the reference variable. So we do see a little bit of differences here. Of course, as in with any study, there are limitations. One would be that we're using one data set, the Mimic4 data set, and that data set only collects data from one particular hospital as opposed to multiple over a variety of geographic locations. So that could be one concern. The other would be that correlation is not always causation. So we're looking at an association between these categories and the outcome, but we might not be able to say specifically that race or sex is causing this difference, right? So there might be other explanations for this association. And similarly, there might be other confounding variables that we did not include in our model. So other variables could impact the association between either other variables or our exposures and our outcome. So in conclusion, race and sex biases affect patient care. And it's important to know where, just so that we can improve healthcare. And if there aren't any, if race and sex doesn't affect particular outcomes, then that's a reassuring thing to know. And then multi-level modeling can be a pretty useful tool in modeling real world data because there are going to be different data structures. And this is great for dealing with that nested data structure. And then so far it appears that there are associations between race and sex and the use of sedation, but further analysis is needed. And we do have some sensitivity analysis in mind. So that's it from me. And I'm happy to answer questions if people have any.
Good job.
I don't know if I should stop sharing or not, but.
Yeah, go ahead, keep sharing, that's great.
Okay.
We're just trying to figure out the microphone situation. This isn't our usual room. Albert, is it okay if we go and use the mic on your computer instead of having to stand over here? Okay.
Okay. Oh no, that caused the feedback. No.
Sorry, yeah, we're still trying to figure out the tech. We're usually in a completely different room. Cool. Yeah, there's a lovely presentation. So you're a CS major.
Yes.
How did all of this connect with CS?
Well, I mean, a lot of what I'm doing is, writing code and stuff like that. From the data set, there's a lot of information that isn't super relevant. And then, there's a lot of generally like data cleaning and data processing to get the important parts that we need. But
cool. Do you also have a stats background, or is the stats part new?
The stats part is actually pretty new to me. After starting this, I was kind of realizing, wow, there's so much stats related to this. Maybe I should pursue a minor or something. So
yeah, medical data is super duper duper interesting. And yeah, there's turns out software, healthcare requires a lot of software. There's a lot of code to be written in that field. I have a couple of friends who do embedded or coding on embedded systems in like heart rate monitors and stuff. And they got into it just as coders and were like, oh, now I need to learn stats and now I need to learn medicine and all this stuff. Cool, super duper cool. Yeah, thank you for this talk. It's a really small audience. It's just us today. Andy's got a question.
Okay.
Can we see the model equation again?
Yes. Which one? Like the code? Oops, I'm going the wrong direction. Like this one or one of the other mathy ones?
The math.
The math one. Oh my God. This one? Or the other one? The one with the representations. I mean, there's like this one with the different split parts. Yes. Okay, great.
We found it. Good job. Andy, do you have a specific question about this, or do you just want to see the thing again? Okay, it seems like we have lost Andy.
Okay.
Oh no, there's the question. There's the question.
Well, J is the like the second level of thing. So it's for each J, you have a number of time interval I's, if that makes sense.
Yeah, these are sort of like different coordinates of the model, right? One is what time it is, and then one is how long is the patient stayed, and these are sort of independent things. One thing I was interested in was when you broke up into the 41 time intervals or 42 time intervals, there was a huge spike at the end, right? The 41st one. Is that because that clustered in everything over a week? Or was that like an actual artifact of how care works?
So I'll go back here, I think. Here?
Yeah, there's
so
big glass thing.
Yeah, so actually, after like the 41st time interval, we're not including any data beyond that, right? So once they hit that like 7-day period, we're excluding all of that other data. So these are just, there's quite a number of patients that do receive more than or equal to 7 days.
Okay. And with your other data set, you had to clean with the propofol data set. You had to clean up this spike at 0, right? Where almost lots of people got no propofol.
Yeah.
Do you also have to clean up this spike at 41 or 42?
Well, this is not exactly like being inputted to the model, right? So we do include, actually the code equation that I showed is a little bit outdated. We do include time interval as one of our predictor values, but we ended up grouping it into like, days like 1 to 3 or something. So over here, and then days like 4 to 7 or something like that. So I guess kind of, but.
Okay, cool. Yeah, I just noticed that these sort of 2 spikes. One of them had to be cleaned up in the data and the other one didn't. So
yeah.
Cool. Andy's our only online person. He also a regular at seminars, so he probably already knows the drill. I'll just put it in the chat anyway. So if you've got some feedback about this talk, please put it in that feedback form. We'd be happy to share our feedback with you. That was super duper good. Sarah, regarding next steps, if you could send me the slides, I'd appreciate that. I'll put them on the webpage. Once the recording is available, I'll put that on the webpage as well. And yeah, you can put it on your CV or your website or whatever you want. That was a great talk. We don't often have stats heavy talks in this seminar, so it was cool to see how CS and healthcare and stats can all make something cool.
Yeah, thanks for having me.
Yeah, our pleasure. Yeah, best of luck. Bye-bye.